even more enthralled to be here because it's just not as a clinician. I'm also one of those who suffered from a cardiac disease for the last 30 years. So in a sense, I'm an expert by experience as well. The theme of this year's World Heart Day is use heart for every heart. So I think the best way to do is for me to convey to you the message, the core message that the World Heart Federation wants to share with the rest of the world. World Heart Day is an opportunity for everyone to stop and consider how to best use your heart for humanity, for nature, and for yourself. Beating cardiovascular disease is something that matters to every beating heart. It's everybody's business. Use heart means to think differently, to make decisions, to act with courage, to help others, and to engage with this important cause. The heart is the only organ that one can hear and feel. It's the first and the last sign of life. It is one of the few things with the potential to unite all of us people. And when we say for every heart, it involves the use of the word for. Now, this swings the focus from the action themselves to the beneficiaries of the action. So allowing the wider application of this campaign. And the aim of the World Heart Day message is to reach as many individuals as possible to achieve cardiovascular health for every heart, raise awareness. And that's what Aisha was talking about. Now, the three key beneficiaries for this day is, the first is use of heart for humanity. So accessing treatment and supporting cardiovascular disease, it varies across the world. The challenge for us in low-income countries is that 75% of deaths occur in low to middle-income countries. But the access is an issue everywhere, but even more so in the lower-income countries. By getting involved with such events as today, and as well as in similar activities, the aim is to spread awareness, to help make a difference in the lives of all humankind. The second beneficiary is the use of the heart for nature. Now, air pollution is responsible for 25% of cardiovascular deaths, which is almost 5 to 7 million people dying every year. Whether they are more immediate actions like walking or cycling instead of traveling by car, or longer-term efforts such as supporting clean air legislation, each of us can contribute to a healthier planet in our own way. The third main beneficiary is yourself. Use the heart for yourself. Psychological distress can double the risk of having a heart attack. Hence, for a mental health professional to have significant interest in this as a professional as well. Exercise, meditation, getting enough quality of sleep to help you lower your stress levels, and seeking help if and when is required is critical. By resisting the harmful coping mechanisms and bad habits induced by stress, we can maximize our individual cardiac health. So, let's use our heart for healthcare access. Let's use our heart for peace. Let's use our heart for education. Let's use our heart for clean air. Let's use our heart for forests, for reducing waste, for lowering blood pressure, for a healthy lifestyle, and for good physical activities. With this, I hand back over to Aisha. Look forward to some of esteemed speakers, including Professor Rod Taylor, Jamal from Bangladesh. We have Dr. Sumro. We have then Professor Nusrat Hussain and Professor Zainab Zadeh. Thank you very much, Aisha. Let's continue with the day.
So much, Professor Imran. Now we would like to move forward and invite our next speaker, Professor Zainab Zadeh, to talk about some cardiovascular diseases and multimorbidity and the impact of depression and anxiety. Professor Zadeh is a professorial scientist and head of division, child and adolescents mental health at Pakistan Institute of Living and Learning. We welcome you, Professor Zainab. Over to you.
Thank you very much, Aisha. Assalamu alaikum and hello to everyone. Thank you very much, Dr. Imran, for beautifully setting the stage for my talk. When you spoke about thoughts, it was where you were trying to help audience understand how head-heart connection is important. And when it was about heart to heart, you were referring to feelings. And that's where anxiety, depression, helping behavior comes in. So the ground that has been set for this talk helps me highlight the factor that how depression, anxiety, and other mental issues or emotional issues or well-being for an individual is connected with cardiovascular diseases. Understanding this, that what is the huge burden that we are all globally experiencing? Cardiovascular diseases are considered to be one of the number one cause for death globally, and around 71% of people die due to cardiovascular diseases, which means in every 2 seconds, somebody is losing their loved one either through heart attack or other cardiovascular diseases. So that's a huge burden. Earlier we used to think that everything that is related to cardiac arrest or cardiovascular diseases, it's about the disease of being of an elite class. But now with the research and the facts, the key facts which are available tells us that the story is different. There are 75% of people from low-income group countries who die of cardiovascular diseases. So considering this helps us understand that the key factors or key facts related to the statistics globally with reference to this disease tells us that the burden is huge. Next slide, please. Next slide. Yeah. No, I can't see that. Yeah, thank you. Okay, so the story is same in Pakistan. When we see the statistics, when we see the list of 50 death causes in Pakistan, the story is same. The cardiovascular diseases, cardiac arrest goes in the number 1, and stroke in number 2. So this, it tells that facts are same in Pakistan as well. Next slide. Helping us understand that it's a huge burden that we need to address and work with reference to how this is connected with mental health of an individual, and how this actually plays an important role in functioning, and the body functioning gets affected by that. So the multimorbidity that we see with cardiovascular diseases is anxiety and depression. Most of the people who experience any of cardiovascular problems, they report to have history of anxiety and depression. And how this works is there is this physiological pathway and there is this behavioral pathway. The person is going through any stressor. As I said just a few minutes ago, in every 2 seconds, if somebody is losing their loved one, which means trauma, anxiety, and at times this is happening in an emergency. So, which means that stress, anxiety, burden of depression is somewhere being added in this whole process. And the life circumstances with financial constraints, other challenges that we have to go through while living our lifespan. So, which is actually adding up to anxiety and depression and stresses. People who experience anxiety, depression, and stress at very high level. As a physiological pathway, what happens is that we're aware of this fact that the cortisol level goes high. There are certain other biological, certain other physical changes in the body which influences the blood flow, and there are, in return, there are certain connected behavioral pathways that we see. People get into the habit of not being very active because they're anxious, because they're depressed, or they have had cardiac experience, cardiovascular disease experience once. So what they have is that anxiety which carries in them. They carry that anxiety, and as a result, either they become inactive in their lifestyle, or the eating habits are not healthy, Smoking and other activities increases. There is less compliance to medication. So there is this cycle that goes on, which leads to increased calcification in arteries and leading to cardiac failure or other cardiovascular diseases. So that's how this cycle goes on. So understanding this connection and the relationship between how our lifestyle and our emotional well-being is affecting the whole body and the functioning is very important. There are a few other points that I would like to highlight here, for the clarification and just sharing some of the thoughts here, that mental health conditions are considered to be associated with cardiac diseases with reference to, as I said, the stress level goes high. And there are certain evidences available. Meta-analytical research shows that depression and anxiety is reported to be connected with increased mortality in cardiovascular disease patients. There is this cohort study, which I'll be talking about or sharing towards the end as well, which is conducted with reference to seeing the relationship between depression, anxiety, and cardiovascular disease, and in which reported that 66% of people experiencing cardiovascular diseases reported to have depression. Can I have next slide, please? Clarifying that how connected or correlated these conditions are. When somebody experiences depression, anxiety, or stress, what happens is there are certain bodily changes, certain lifestyle changes. But other than that, what happens to the other way around is that if somebody experiences any, they have had any cardiac issue, the apprehension or the fear or in a way, anxiety to have that attack again or to be in a health or life risk experience, that adds up to their depression and stress and anxiety more, leading to different other changes in the body and increased in their behavioral, unhealthy behavioral pattern and lifestyle, leading to more high risk towards cardiovascular diseases. Adults with depressive symptoms show poor physical health outcomes and increased risk of mortality is being reported with reference to that. Can I have next slide, please? Especially in urban areas, the way lifestyle is being changed and the pressure is there. These are some of the evidences done through our platform, Pakistan Institute of Living and Learning. What we have been able to contribute in this direction is I'm pleased to report, or I'm glad to share these two researches. One is a mixed study and the other cohort, which I've been talking about just a few minutes ago. This in itself tells that how important it is to actually start working in this direction, understanding that mental health is to be given importance globally, well-being is to be given importance globally. Why? Because it's greatly connected with physical conditions of people. The mixed study with reference to knowledge, attitude, and practice towards community cardiac rehabilitation and multimorbidity in Pakistan, where the survey was completed on 230 people. There were certain different agencies involved in it, where certain qualitative interviews were also done. And there is this other study, which have been a cohort study. In this also, there was 66% of the evidence confirming the idea that there is a great correlation between depression and people experiencing cardiac problems. So just to conclude my talk, I would just like to highlight that it's not only talking about this fact, but contributing in this area through our work, and this is some of the evidence. Just explaining this, that this is important to understand that how head-heart connection and feelings connected with that can bring change in somebody's life. This is about Dil Ka Mamla, what we say, and that needs to be given a lot of importance. And with this year's slogan of mental health, World Mental Health Day being giving priority to mental health globally, it's high time that we give importance to it and understand that, yes, darde dil ke waaste paida kiya insaan ko. That's kindness for which deed of help that we have been created in this world, which actually influences the bodily function and especially cardiac functioning well. Thank you very much for your attention.
So much, Professor Zadeh, for highlighting the work that Pakistan Institute of Living and Learning is doing in this domain, and ending up your talk with a very poetic lines that were very beautiful. Thank you so much. Now, we would like to move forward with our next speaker, but we have received apology from Professor Tahir Sagir. I'm sure that if he was there, he would definitely going to have a great enhancement in our knowledge regarding this domain. So now I would like to invite Professor Dr. Nabila Somru to highlight the importance of cardiac rehabilitation in low and middle income countries. She is an executive director at Sindh Institute of Physical Medicine and Rehabilitation, cardiopulmonary rehab consultant, and at National Institute of Cardiovascular Diseases. Thank you so much, Dr. Nabila, for joining us today. Over to you.
Bismillah ar-Rahman ar-Rahim, salam and hello to everyone. And I must thank PIL stakeholders, especially Dr. Imran, to have me and realizing the importance of rehab as a part of management of patients with heart disorders. So I would just like to ask, am I audible on audio, or would you like me to start the video? I don't know, whichever. I would just ask the...
You're quite audible, Dr. Nabila, and if you can turn on the video, that's perfect as well.
Okay.
Thank you.
So let me turn on the video and see if, I can be heard clearly. So today I'll just share what's happening in Pakistan regarding cardiac rehab. And as we all know that cardiac rehab is very integral part of cardiology. So here we are offering a multidisciplinary cardiac rehab at Sindh Institute of Physical Medicine and Rehab and at NICVD. The reason of me shifting my services partially to NICVD was that I realized that at our institute, there were very few referrals. So we thought we'll sit at the heart of tertiary care cardiac hospital so that the surgeons, cardiologists, and other team members realize the importance of cardiac rehab. And, we have more referrals and we can just move forward and we can have more patients and we can propagate our rehab multidisciplinary team task to many patients. So can we have the next slide, please? Or is that slide in my control? Okay. So we all know that cardiac rehab is a process. Once the surgeons and the physicians, they complete their work, then we come into play and then we work on their physiological, making them independent and physical activities, whatever the function of the heart is, whatever the capacity of the heart is, psychological. Psychosocial factors are major factors, as the doctors and professors before me spoke. It's an integral part of one of the risk factors of cardiac rehab. Social, of course, once a heart even, so we have to bring the patient back to normal. Vocational, the main anxiety is whether he can go back to the same work and same recreation. So that's our job. And emotional status. So psychological and emotional, they just go hand in hand. So of course, cardiac rehab is a medically supervised program, which is multidisciplinary and it's individually tailored because no one patient can have similar risk factors. Can we go on to the next slide? I was told I have 5 minutes, so I'll quickly. So under one roof, we have a team which revolves around the patient, and the team members are, of course, the patient comes first in contact with the cardiologist or a cardiac surgeon. So invasive cardiologists and cardiac surgeons are the first members which patient encounters. And then comes we as a rehab physicians, we are called physiatrists. And then and then we make their plan of cardiac, that what will be the plan which we'll be offering them. And then we pick and choose from our team. So the rest of the team members like physiotherapists, nutritionists, psychotherapists, rehab nurse, and of course psychiatrists. If we think that the psychotherapist is not able to handle the things and we still are facing anxiety and depression, then we involve the psychiatrist or we refer them, but they're currently not on the floor. So, and of course, now the major cause, like we'll soon discuss, the major risk factors is a sleep therapist. Sleep again is so you can see I've included occupational therapist and orthotist, prosthetist in the team, because most of my patients, cardiac patients who are referred to us also suffer from stroke. So at times we have to deal with two challenges. So this is our core team these are our core team members which work under one roof to offer multidisciplinary cardiac rehab services. And I'm sure everyone knows their role. Social worker, because I'm working at both hospitals, these both programs are free of cost. So of course, social workers is there, but then, their role is not as active as it should be in private setups. So my next slide is about who can benefit. So everyone, I think almost everyone, there are few contraindications. So even the contraindications, once we overcome the contraindications, then we can take almost every patient. So heart surgery, all procedures of invasive cardiology, heart and lung transplant, and any unstable angina or unstable angina, any recent heart attack, heart failure. So these are the patients which we take. Next. And I think benefits are so many that I thought if I'll speak of the benefits, I might lose my 5 minutes time. But then just to, concise is that, you work on your major cardiovascular risk factors. And through them, you engage them in daily activities and you adhere to the rehab and the cardiologist or cardiac surgeon or a psychiatrist or any member of the team treatment plan. So we ensure that through our phase 1, phase 2, phase 3. Phase 3 ends during first year. Now phase 4 is also added in last 5 years just to ensure that the patient overcomes his risk factors. So for phase 4, we follow the patient for another year. So I'll take last few minutes to quickly go through the latest risk factors which are leading to heart events. And we all know that it's a number 1 killer. So my last slide will explain it all. This I designed because I'm part of International Cardiopulmonary Rehab team. So we had designed it 5 years earlier. So a year later, the risk factors we might be adding, and might be few risk factors might come down and few up. But currently for the last 5 years, I would just say that physical inactivity was labeled as number 1 risk factor for heart disease. So anyone who's walking less than 10,000 steps per day is a person who's prone to heart attack. Okay, and that means, and you can have aerobic exercise of 30 to 60 minutes 5 times a week. And resistance exercises are very important. Why? Because with age, we develop sarcopenia. And once we develop sarcopenia, that is loss of muscle mass, our BMI goes down, our aerobic capacity goes down. So 2 to 3 times per week of resistance exercises. I don't want to go into the detail. Wish we had more time. I would have elaborated this. So number one risk factor for your heart attack is physical inactivity. Number two is nutrition. You need hours and hours to talk about nutrition, but simply your total intake of calories, the fat should be less than 30%, and no more trans fats or saturated fats. So agar isko simple way mein kiya jaye, so every person is allowed 1 liter of oil per month, but that also of a vegetable origin. Sodium आपको 1 teaspoon से कम लेना है रोजाना, because that contributes to your DASH diet. Sugar intake, men को कहते हैं कि we can never go up to more than 9 teaspoons. Women and kids not more than 6 teaspoons. And this includes all sugars, our rice, our fruits, everything. All sugars. This doesn't mean a refined sugar. Fiber, at least 30 grams per day, which roughly includes 2 different colored fruits and 3 times vegetables per day. So they saw that physical activity was number 1 cause of heart attacks. Nutrition was number 2, and psychosocial factors. Of course, we've laid so much importance that our colleagues have already spoken about it. So depression, distress, the kind of personality you have, if you are not social, if you're irritable, and if you're stressful, so that kind of personality is again a big invitation for heart attack. And the major role in psychosocial factors is sleep. Sleep was labeled, I think when next year we'll have separate, a different risk factor assessment. That will be like, we'll have less than 5 hours or more than 9 hours is again a risk factor. So sleep is an independent risk factor, and sleep apnea, of course, is a major cause of risk factor. I think that risk factor slide has disappeared. If I can have it for a few more minutes. And then comes inside, after psychosocial factors, we can have like a waist circumference. So our waist circumference for Asian women, we cannot go beyond 32. And for males, we cannot go beyond 35. So for Americans and Japanese, they're different because their mode of eating, their physical activities, and other factors are. Can I have the slide prior, one slide before this? The risk factor slide. Can we display that? So if you go take home messages that these risk factors, if they are taken care of, and if we counsel our patients, because psychiatrists will talk about anxiety, depression, everyone will talk about their own domain. But these factors together are major risk factors. And it's noted that if we take care of our waist size, our physical activity, psychosocial factor, nutrition, smoking and tobacco, then our blood pressure, our blood glucose and serum lipids, they'll all be taken care automatically. So these risk factors have come down. So, I just wanted to emphasize that all our cardiac events revolve around these risk factors, as far as, the latest risk factors which we've studied in last 5 years. So with that, I thank you all for, sparing your precious time and listening to my talk, and apologize if I've gone a few
Thank
minutes
you very much,
beyond.
Dr. Nabi.
Thank you so much.
Wonderful talk. Thank you very much. Aisha, beta.
My apologies. There was some internet disconnection.
That's okay. Let's move on.
Okay. Thank you so much, Professor Nabila. That was quite insightful for us all. And now we will move forward with the slides of Mr. Jamaluddin. We would like to request him to put some light on affordable cardiac rehabilitation and outreach interdisciplinary strategic study. And Mr. Jamaluddin is resides in Bangladesh, but currently he is a PhD fellow at University of Glasgow, Scotland, and he's doing his PhD in social and public health sciences. Welcome, Mr. Jamaluddin.
Jamal, you wanted to share your own slides? Shall we take this off? So
Yes,
you
thank
can-
you so much. Thank you so much. Can I share my slide here?
Absolutely.
Yes, please.
Yes, thank you so much for giving me such an opportunity. Assalamu alaikum and good evening. Can you hear me?
Yes, we
Yes,
can.
you're quite audible.
Okay, but yes, I am actually feel fear at that moment because of electricity and the internet connection. It's like a heart failure, heart attack. However, I just want to go forward. I'm Jamaluddin. I'm a PhD research student, University of Glasgow, and MRC CHU Social and Public Health Science Unit. First of all, I'd like to give the background of cardiac rehab establishment in Bangladesh. They have a nice collaboration in Bangladesh. In 2019, Bangladesh got a unique opportunity to cooperate with Denmark, UK, Canada in collaboration with 3 renowned cardiac hospitals in Bangladesh in a cross-national project aiming to move cardiac rehab forward in Bangladesh. And here is the, collaborators here in Bangladesh. We have some 2 hospitals, and also from Denmark, REPA, the Danish National Center for Rehabilitation Palliative Care head, Professor Andrew Juisler, and also University of Exeter, but now he is Professor Rod Taylor. He is based in Glasgow, and also Mr. Said, who is coordinated from Denmark. And this, my today's topics is the byproduct of this project. And this is the project that across project Bangladesh part phase 1, the validation of the heart call in Bangladeshi patient with coronary heart disease. And this is the main topics today's. And here in the left side is original heart questionnaire in English. And we did this validation on the heart call in Bangla version questionnaire and translated it. Here in the right side is the Bangla version of the heart call questionnaire. The aims and methods of this, the heart call questionnaire is designed to assess the health-related quality of life patient with different heart disease. The aim of this to validate the heart call Bangla version questionnaire in Bangladeshi patient with myocardial infarction and or angina pectoris. It is actually a cross-sectional study, and 2 hospitals were involved with this for data collection, Ibrahim Cardiac Hospital 1, and another one is National Heart Foundation Hospital and Research Institute. And we did collect, we include the patients who are admitted for PCI or coronary artery bypass graft surgery during the period of April 2019 to October 2019 with confirmed diagnosed of MI or angina. And the age group equal or more than 18 years of age without need for emergency medical care or the presence of any psychiatric disorder. We did the forward-backward translation used to prepare the Bangla version of this questionnaire, and we use a heart quality of life questionnaire, EQ5D questionnaire, GAT7, and also PHQ9 for angina and depression. And we completed all the questionnaire before PCI and CBG, and then follow up 4 weeks to 6 months. And we finally got 1,041 completed data, which was analyzable. And here is the demographic and risk profile in a simple way. The mean age is 55 years of age, and the male are predominant, and the diabetes also is more high, here 58%, and the LVEF more than 45% is 64.9%, and the smoker, in generally smoker is a high percentage. It's about 60%, more than 60% current and ex-smoker, and physical sedentary is about 38.4%. And in the also the hypertension, it's about 86% of patients are hypertensive. So it is very alarming. Now comes to the hardcore floor and ceiling effects and reliability. Heart call score, global score was 1.87, physical score was 1.81, and emotional score 2, which is acceptable and very nice score. And heart call floor or ceiling effects. Heart call floor effects on each scale were equal or less than 1% in the total, and also ceiling effects physical and global score were equal or less than 3%, and the ceiling effects on the emotional subscale were in more 16% of the total group, which is a little bit high. Actually, need to less than 15%. And the heart call reliability, if we talk about reliability, the internal consistency reliability was confirmed with the Cronbach alpha, which is ranging from a 0.86 to 0.86 across the total group, where MI ranging from 0.83 to 0.86, and for angina 0.75 to 0.78. And this is the discriminative validity of heart validity. Is actually the type of constructive validity. We use the EQ5D3L visual analog scale cutoff point equal or more than 80%. It is about 2 in global, and physical 1.97, and emotional 2.15, which is highly significant and confirmed that hypothesis is accepted. And also in the same way for PHQ-9 cutoff point, and also for GAT7 cutoff point, and all the way they confirm the hypothesis and highly significant. So this discriminative validity of the Bangla version heart call questionnaire was confirmed the EQ5D3L, GAT7 anxiety, and PHQ-9 depression. The result was largely consistent with the original validation of and with other different previous published heart call studies. And now comes to the mechanical analysis, the result and discussion part. In mechanical analysis, Bangla heart call factor structure is consistent with the original 2-factor structure, actually the physical and emotional subscales, and also HI coefficient, emotional subscale mostly strong. We got the most emotional subscale mostly strong from 0.56 to 0.60, and physical subscale are moderate 0.44 to 0.50. But we got also 3 items from where is very weak, ranging from 0.36 to 0.39, which may reflect ambiguous wording of substances in a future study. We need to do some future study to adjust the language. And the test to test responsiveness, the heart call global, physical, and emotional subscale score were highly significant and improved with the following coronary artery bypass graft surgery and also PCI's interventions. And also the effect size was 0.60 for the heart call global and 0.68 for the physical, and also for emotional subscale is 0.38. Discussion, the good internal consistency and responses of the Bangla version heart call questionnaire is consistent with the previous language different validation of studies of heart call. In conclusion, the overall Bangla version of heart call demonstrated satisfactory psychometric properties, demonstrated high internal consistency, and also discriminated validity is a very good, and responsiveness. So however, before it can be recommended for the routine use in the clinical and research, but we need some items may need to be rephrasing. And I would like to acknowledge for this study funding from REPA, Danish Knowledge Center for Rehabilitation Palliative Care, Denmark, and University of Exeter, UK for their joint institutional seed funding. And thanks to Ibrahim Cardiac Hospital and Research Institute, and also National Heart Foundation Hospital and Research Institute for their administrative support in cooperation. And lastly, I would like to thanks to all the participants who contribute to this study. Keep smiling and stay safe. Thank you so much.
Thank you so much, Jamal, for sharing your work with us. It was really very insightful. Now, I would like to invite Dr. Rod Taylor to give us an overview of the project across. Professor Taylor is a professor of population health research, MRC CSO, Social and Public Health Research Science Unit, and Robertson Center for Biostatistics at University of Glasgow. Welcome, sir. Over to you.
Thank you very much, Salam, and happy World Heart Day from UK. So first of all, my sincere thanks to PIL for organising this very nice session on such an important day, and then also inviting myself and fellow colleagues to present to you today. So what I'd like to do in my 5 minutes is talk to you about the Across collaboration. You've already heard a little bit about this from Yamal. His project is effectively an output of this collaboration that began some 3 years ago. I'll show you the partners in a moment, but I think it's important in days like Heart World Day that we reflect on what our visions are. And our vision, I think, of Across is ambitious. We want to ensure global access to affordable, effective rehabilitation for people with heart disease to enable them to lead longer and healthier lives. Because as we heard from Professor Samro, there is very good evidence that rehabilitation works, but access is incredibly variable, dependent on where you live in the globe. And sadly, if, for instance, we were to look in South Asia, in some parts of the countries, Pakistan, India, Bangladesh, the services are virtually nil. And that's something that can't continue. And indeed, even in UK, a fairly well-funded health service, we know that only 1 in 10, for instance, of our heart failure patients who could benefit from rehabilitation are currently doing so. So this is a joint global collaboration where we need to come together and fix this problem. Next slide. So how are we doing that? Well, in this collaboration, we brought together, I think, an absolutely stellar clinical and academic group of individuals. I've tried to summarize them here, and forgive me if I've missed anybody off of this slide, but I think as you can see from the columns, we've got our India, Bangladesh, Pakistan colleagues, Pakistan led by the Institute of Living and Learning who are hosting this call. And then in United Kingdom, we have the University of Glasgow, where, as you've heard, I have since moved to, but also the University of Manchester, where we have Professor Nusrat Hussain. And as I'll speak to in a moment, that link, I think, for us is very important here. And then last but not least, we also have the pleasure of some international partners who are with us in an advisory capacity. We've got Professor Sherry Grace from Canada, David Hare from Australia, and Professor Andorras Visler from Denmark. Next slide. So one of the things that we want to do, so you've heard that we've been undertaking some small research projects, but we do have an ambitious game. And what we're about to do is apply in United Kingdom to a new NIHR call called RIGHT6. We did apply 2 years ago. We got very good review, but sadly, because of funding restrictions, we didn't get the money in the end, but we're going to have another go. So what are we going to address in this project? Well, we're going to address the following question. And the question is, can we implement a culturally adapted home-based cardiac rehabilitation program for people with coronary heart disease or heart failure or coexisting mental health conditions, depression or anxiety? And can we do that and demonstrate that these services are clinically effective, cost-effective, sustainable, and importantly, scalable, as we were discussing before? And I think it's important to reflect that I think if you've heard our previous presenters, people who present to cardiac rehabilitation programs may have an index diagnosis of a cardiac condition, but they're often highly multimorbid, right? And as we've heard from one of our previous speakers, a very key driver of their cardiac disease is the vicious cycle between cardiovascular disease and mental health. And we need to break that. So this program is purposefully looking at the challenge of multi-morbidity alongside the provision of rehabilitation. And I think that's important. So the way I often put it is we want to treat our patients, not treat the condition. Our patients come with many conditions, and it's at a patient level we need to think. Next slide. So how are we going to do this? Well, I guess perhaps before I say that, this is just to recognize the fact that we have done a number of randomized controlled trials in the UK showing that home-based interventions can be highly effective. And of course, the advantage of home-based interventions is that they increase our reach of rehabilitation. Now, that's not to say, as Professor Samru said, we might want to bring some patients into the hospital setting, but I think home-based rehabilitation lets us reach this ambition of scalability. And we've got 2 interventions in UK called the Heart Manual and an intervention I've been involved in designing called REACH-HF. And we want to, if you like, take them from a UK setting and adapt them into our South Asian setting. Next slide. So we're proposing to do this through 4 work packages. The first work package is to take the 2 interventions I described and to culturally adapt and refine those interventions. And that work will be led by Professor Karina Lavelle, who's based at the University of Liverpool. Next slide, next click, thanks. What we need to do once we've got our intervention is then to ask the question of, can we do a pilot randomized control trial in each of our 3 countries? So what we would plan to do is take 2 sites in each of our 3 countries, 100 patients, randomize them to the new intervention and test the acceptability of this, and also whether the trial design is feasible. Can we recruit people into these studies? As you heard earlier, it's very important we get referrals. Without referrals, we're dead in the water, so we can test these things. Next click. If that external pilot goes well, or the lessons from that will then inform a full multi-center country randomized controlled trial where we will take 1,000 patients in each country, approximately 50% MI, 50% heart failure, and assess the composite outcome of mortality, hospitalization, and quality of life. My apologies for the background noise. I'm at a conference and the plenary session has just opened the doors and everybody is now exiting. So you're going to hear a little bit of background noise. I do apologize. I'm almost finished. Work package 4, click again, please, is led by Amy Blakemore, and Amy is again in Liverpool. And this is important because not only do we want to deliver research, but we also want to build clinical and research capacity that's long lasting in each of our 3 countries that includes PhDs. And I'm delighted to say that Yamal is the first of our PhD students. Next slide. So I'd like to finish there. This is, first of all, our logo. So you can see our cross logo. We've got the globe. We want to change things at a global level. And we need to do that by bridging our various collaborators together. This is our website. If you haven't been there, I'd encourage you to attend. And again, happy World Heart Day, and my thanks for letting me join you today.
Thank you so much, Professor Taylor. Now I would like to ask the audience if they have some questions from our panel members. They can ask. Do we have any question?
This is Dr. Nabila, not a question, but the first cardiopulmonary rehab started at Institute of Rehab Medicine, so that we need to add in the list where Pakistan is. That's my only addition to.
Okay.
Noted, Dr. Nabila. Thank you.
Thank you.
Thank you, Nabila. And I should say that that slide I showed you is somewhat out of date. So Imran, we need to update that for our new application, right?
We do.
I would request you, Professor Imran, for a thank you note to the audience and the speakers.
So it's been really heartwarming to listen to some very eloquent talks. Work from Bangladesh, work from Pakistan, and to have this prestigious moment to have Rod with us again. Rod is the inspiration behind bringing us together to improve particularly the cardiac rehabilitation in South Asia, including Bangladesh, India, and Pakistan. So it's wonderful listening to the speakers. I think I would go back to what we started with, that beating cardiovascular disease is something that matters to every beating heart. And the motto remains, use heart for every heart. We can all make a difference. With this, I thank you all. Thank my speakers for taking out their time. Thank you very much for Pakistan Institute of Living and Learning for organizing this event, and particularly Aisha and Amir Bash. And thank you all for listening patiently for the last 1 hour. Looking forward to more such events to increase awareness and pursue our goal of better cardiac health in Pakistan. Thank you very much.